Dr. Wen, patients that live in rural areas, like the district that I represent in Pennsylvania, often face barriers that impede their access to health care. Do you believe that AI has the potential to quash those impediments? And if so, how can we incentivize further adoption of AI technologies?
Thank you for the question, Congressman. Absolutely. The distribution of care to rural areas and the barriers to access are well known and great. AI can quash those barriers and really close those gaps in a few different ways. First, there is always a supply and demand problem when you think about distribution of resources across rural areas. Making clinicians more efficient, right? Making clinicians more available means that there are more clinicians available to see those patients in rural areas. Two, many of the barriers come also from a lack of health literacy, a lack of access, right, to the healthcare system. AI also can help patients in rural areas level the playing field, right, by assisting them in better understanding their care, better navigating the care system, and better understanding how to find the best care for themselves. The incentives, right, that Congress can encourage, right, include the development and education of AI skill sets across the healthcare system, but specifically in the clinicians who are going to practice in rural areas and the healthcare leaders who are going to lead systems in rural areas. That education is very, very important, as I mentioned in my statement. It doesn't come naturally to many of our institutions, but it's, yeah.
Thank you. Dr. Schlosser, welcome to another Johns Hopkins trained physician. I took that to Congress, you took that another direction. The FDA has been regulating some forms of AI under existing authorities for drugs and biologics, as well as medical devices. Do you think that the current regulatory structure is sufficient to keep up with the innovation in AI's uses in healthcare?
Yes, and thank you for the question. I actually have some experience. I was a medical officer for the FDA a number of years ago, and I would say that the rate at which AI is changing healthcare is likely going to require us to think a little bit differently about how we regulate medical devices. The current approach, which really is based on laws from 1974, I think never really anticipated the kind of technology we're talking about. So dealing with models that can learn over time is something that we're going to have to work together, I think, to figure out what that regulatory pathway looks like. There's incredible potential here, but I feel the movement and the progress of AI is a little bit outpacing the current regulatory approach.
Thank you. And Chairman Guthrie, briefly before I yield, I ask unanimous consent to enter into the record a letter of support from the American College of Surgeons.
Seeing no objection, so ordered.
Thank you, and again, thank you for the witnesses for being here, and I yield.
Thank you. The gentleman yields back. The chair recognizes the gentlelady from Tennessee, Ms. Harshbarger, for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you all for being here. I've heard a couple of you speak before. This is really interesting stuff. And I'll start with you, Dr. Schlosser, since you're from Tennessee or HCA. Let's talk about the pharmaceutical supply chain, and it can be very difficult and complex to trace. And as a pharmacist, I'm responsible for knowing every step in that process in the supply chain, from the manufacturer to the dispensing of the drug because of the pedigree. How can AI be used to help pharmacists in their role optimizing medication use and patient health outcomes, improve providing patient care? How can we use that? And hopefully we can be reimbursed for that.
Yeah, well, thank you, Congresswoman, for the question. And I think there's tremendous opportunity. We actually already use varieties of artificial intelligence in our pharmacy processes, and we've actually done this for years. We have heuristic models, which are basically rules-based models that are constantly surveilling patient charts, looking for opportunities that can serve up to the pharmacists, be they drug interactions or substitutions or places where we can be more efficient or provide more effective treatment. And so I think those models are only going to improve and get better with the advent of these more advanced artificial intelligent algorithms. I think the same is true for our pharmacy supply chains, and we've mentioned this already today, but the ability to get predictive in understanding the demands and needs of our patients, on a hospital or even unit basis, and then be able to go back upstream and ensure that we have the adequate supply to meet those demands. And if we don't, can we make kind of preemptive steps to ensure that we can maintain adequate supplies is another area that we're already working on, and I think there'll be great benefit.
Very good. You've already told us about how HCA, the hospital system, sees value in the adoption of AI technologies without even additional payment in that. And you've talked to us about removing the administrative burden and its reduction of time spent that does not involve direct patient care. So this is my question, and this is your chance to tell me what to do. What recommendations do you have for this committee in creating payment models in AI for healthcare services, application, and add-ons?
Yeah, and some of my panelists have had a chance to weigh on this already today. I do think as this technology advances and it becomes more a meaningful and central part of healthcare delivery, that CMS is going to have to find an approach to reimburse for this technology. And in my personal opinion, it's not that different than the initial approaches they tried to take around chronic disease management of how do you reimburse for sort of the ongoing work that in this case an algorithm would do to help prevent complications, to help reduce cost. The last comment I want to make here is that I think we have a great opportunity with AI, since we're at the beginning, is to take a business case-minded approach to how we deploy this technology and not have it just be another technology that we deploy that adds more cost, and then we try to add more reimbursement and therefore drive up the cost of the healthcare system, but instead be really thoughtful about how can these technologies make us more efficient and more effective and decrease the overall cost of the healthcare system as we deploy them.
Well, we're going to have to. So you will continue to exist. Dr. Longhurst, how do you think AI and medical liability intersect?
Fantastic question. Thank you. As was previously mentioned on this, AI is a tool, whether it's being used for diagnosis or treatment options or others. Ultimately, the liability for treatment of the patient rests with the treating physician.
Yeah.
And so we've had perhaps not AI tools for a long time, but we've certainly had clinical decision support tools for a long time that suggest potential drug-drug interactions or dose range errors and other things. And the liability has always rested with the treating clinician to see these alerts, manage them, but make the best decision for the patient. So I think the real question about liability in AI comes if you take the human out of the loop.
Right.
If there is a step that's taken towards making diagnoses without clinicians, then it begs all sorts of other questions about licensing these tools.
Yeah, exactly. Do you see a scenario where litigation might increase if doctors don't utilize AI?
That is a fantastic question as well. In fact, a recent Boston Globe survey of patients asked, would you see a doctor that was not using AI? And the predominant answer from patients was, I would be concerned if my doctor was not using the latest tools.
Okay.
So I think, as was recently described by Dr. Newman-Toker, if these tools are shown to be best practice, if they can decrease mortality, if they can increase survivorship, then they will become a best practice that should be used in every case.
Okay. Thank you, sir. And I think I'm out of time, so I yield back.
Thank you. The gentlelady yields back. The chair recognizes the gentlelady from Iowa, Dr. Miller Meeks, for 5 minutes for questions.
Well, thank you very much, and I just want to add in my own personal experience with electronic health records as a doctor, and it's much more than 2 hours of my time after seeing 35 to 40 patients in a day. Just as an example, on a global post-op no charge, after I finished completing my medical record, it took an additional 6 clicks to put in no charge. Now it takes me 10 seconds to write in-C. It took 2 minutes to 6 clicks to no charge. So it certainly does lead to burnout. I'd also like to follow up on something Dr. Longhurst said, and then also Dr. Schlosser. And certainly the FDA has not kept up with medical devices utilizing artificial intelligence, not only generative, but repetitive machine learning. And at the University of Iowa, Dr. Michael Abramoff, MD, PhD, has one of those first medical devices that's approved by the FDA. And then I'd like to submit for the record an article on effectiveness of artificial intelligence screening and preventing vision loss from diabetes, a policy model. And then that would lead to reimbursement. And what's great about this is that it increases access by having a device that can be put into any person's office, whether it's an eye care provider or family practitioner. And then the second letter is a letter of support from Johnson & Johnson that does talk about privacy, equity, bias, and transparency in the system, since those things have been brought up.
Thank you. We're going to accept the documents list at the end. We'll make sure those are included and give my friend here a chance to review. Thanks.
I know I did it first because I'm older and I forget things. Mr. Shin, we've heard a lot about AI over the past few years and the potential risk attributed to unregulated AI integration. However, the FDA has been regulating software-based medical products since the 1970s, and we know that AI integration into healthcare has already raised the status quo of care. We have seen it in digital pathology, drug optimization, integration in patient engagement, personalized risk prediction. Can you give examples where gaps exist in current regulation that Congress can address to ensure continued innovation that will drive better, more personalized care for patients without burdensome overregulation?
Yeah, thank you for the question, Congresswoman. I think what we're seeing with the FDA, and we continue to work very closely with the FDA to try to make sure that they stay current with the rapidly changing technologies that are there. I think the challenge that we're seeing is that, and it was acknowledged here on this panel today, is really how artificial intelligence continues to change, and what becomes an AI algorithm today might be a different AI algorithm tomorrow, or might need to be adjusted or increased in terms of accuracy or whatnot after it's being used in the clinical setting. So I think this is where areas like PCCP that we had worked on here with this committee previously, these are all important aspects that the FDA needs to consider and actually not water down in terms of its ability, because that actually then will inhibit us from being able to continue to develop and innovate in this particular area.
Thank you. Dr. Schlosser, many hospitals and hospital systems are facing significant staff shortages. We're seeing AI as a meaningful tool to help alleviate some of the administrative burdens that are driving providers away from the medical profession. A recent report from Goldman Sachs notes that shifts in workflows triggered by these advances could expose the equivalent of 300 million full-time jobs to automation. What steps can Congress take to facilitate better AI integration to health systems to streamline processes that will allow healthcare professionals to focus more on patients and less on billing, coding, et cetera?
That's a great question, Congresswoman. Thank you. And I think this is incredibly important that we do streamline our ability to use AI to tackle this serious workforce problem that we have that is only going to continue to get bigger. We think the gap between supply and demand for nurses alone is going to continue to increase over the next decade. And so I would say the easy answer is let's not put too many burdensome regulations between us and our ability to deploy AI to support our healthcare workforce. We're not talking about AI directly influencing patients or providing diagnoses. We're talking about it removing administrative burden. That is an area where, with the right responsible AI platforms, we should be able to move quickly to adopt those technologies and free up that workforce to handle this increasing demand.
Well, thank you. And I saw Dr. Nguyen and Dr. Longhurst shaking their heads, so I think that you're in agreement. And since I'm running out of time, I've got another question I'll submit for the record. And with that, I yield back my time. Thank you so much.
Thank you. The gentlelady yields back, and if you'll give us those documents you submitted for the record so we can review those, we appreciate it. The chair now recognizes the gentleman from California, Mr. Obernolte, for 5 minutes.
Thank you, Mr. Chair. Thank you to our witnesses. It's been a really interesting hearing. Mr. Shen, I wanted to ask you about some of your interactions with the FDA, because we're really at a crossroads when it comes to devising a regulatory framework for artificial intelligence. We can either follow the lead of entities like the European Union, who believe that AI is its own kind of unique discipline and that there needs to be a separate bureaucracy spun up to issue licenses with respect to the use of AI, or we can follow the lead of countries like the UK, who has pointed out that because the risk of AI is so contextual, that the existing sectoral authorities are best equipped to regulate within their sectoral spaces with a bunch of technical help and resource. So I was curious. I mean, we have to choose, right? We're at a crossroads. We can go one way or the other way. There's really no middle ground. Which of those two paths do you think we should follow? Is it easier to teach the FDA what it doesn't know about AI, or is it easier to teach a brand new agency everything the FDA already knows about ensuring patient safety?
Very good question, Congressman. I think certainly this is a tricky topic, but I think what we have to remember is that at least in our industry, from a vendor perspective, we have been working closely with the FDA for many, many years here, and we work as Siemens Healthineers. We have direct dialogues with them around this topic on a weekly basis. I think the other thing that's important to remind ourselves here, especially in the context of artificial intelligence, is that AI can't not just be considered as a separate type of technology, but this technology is also being embedded into the medical devices themselves as well. So, for instance, CT scanners or MRI scanners, they have AI that's built in there into that system that allows for better image quality or faster exams for the patient. So a lot of benefits to the patient are happening already with the AI technology built into the medical devices themselves. So we have to consider that, especially when we consider how we want to move forward with the FDA.
Right. I think that's a good point. I also am heartened by your comment that you feel the existing regulatory relationship with the FDA is doing a good job at both ensuring patient safety and catalyzing innovation. And so, I think that's a pretty powerful argument, for maintaining that relationship and empowering the FDA to regulate in that space. Dr. Newman-Tolker, thank you very much for your testimony. You said something that I found incredibly interesting. You said that the best that we can expect from AI is that it repeat the existing human biases that exist in the data it was trained with. And I found that a fascinating statement. I don't like the use of the word bias because it's a very human word. And when you apply it to a machine learning algorithm, there's no such thing as bias. They're all biased. Machine learning is all about bias because you're training it to generalize, and we call that bias when we talk about kind of maintaining our social standards. When we say, for example, it would be wrong to consider someone's race when making a hiring decision. We can all agree that that's true. But that also means scrubbing the data that we use to train AI that makes those recommendations for things that can be used as proxies for race. And that's the difficulty that we've had so far. So you were talking about how important it is in the medical context of maintaining high-quality data sets to avoid those kinds of biases. How do we ethically navigate this space of patient consent? If you have a chest X-ray, and I think it was Dr. Longhurst that was talking about detecting COVID pneumonia from a chest X-ray. If you're a patient, you come in, you get a chest X-ray, you have not consented for the use of that X-ray to be used to train a machine learning algorithm. Do you have the right to say, no, I don't want my data used? And if you do, the problem is that is introducing bias into the algorithm because, from a statistical sense, you're biasing the outcome of the algorithm because who knows what else the group of people who would withhold consent have in common, right? So a statistician would say that's a serious problem. So how do we navigate that space? How do we protect the patient data at the same time avoid biasing these algorithms?
Thank you, Congressman. This is a great question. So, I come from the world of clinical research where there's always the opportunity to refuse to participate, and I'm generally of the mind that should always be the case, that if patients wish to opt out, they do. It does create a certain bias. There's a volunteer bias of those who want to participate, but I think that's a bias we can accept. As far as the issue of the replicating the sort of human biases, as I mentioned in my testimony, I believe that we have this exists at two different levels, but the most important piece is where our biases are causing us to behave differently as clinicians. So if I don't order the same test in a black patient that I order in a white patient for the same circumstance and the same condition and the same appropriateness, that's the kind of bias that I don't want to replicate in my AI systems. And I think that's why well-curated gold standard data sets are so critical.
Yeah, I would agree. And I'm an AI optimist, so I would actually argue against your statement, that the best we can expect is the replication of existing biases. I think it's a golden opportunity to remove the biases. Well, I see I'm out of time, but thank you very much for your testimony. I'll yield back, Mr. Chairman.
Thank you. The gentleman yields back. We now have a vote on the floor, but we only have one member left to ask questions, so we're going to hopefully be able to complete this now. So we'll get started on that. The next member to speak is our Gentleman from Texas, Mr. Crenshaw, for 5 minutes.
Thank you, Mr. Chairman. I'm glad we're doing this hearing. I think we need a lot more hearings on AI on multiple subjects. I think healthcare, utilization of AI in healthcare might be the least of our worries. I also worry that we're not always talking about this in an accurate way. We're not properly differentiating between advanced algorithms and AI. We're just saying AI. And that's not from our witnesses. That's just that's for Congress. That's for America. If we're going to properly regulate it, and I'm going to ask you what you guys mean by that. A few of you have said we need to properly regulate it. I'm genuinely curious how and what we do. But we have to talk about it accurately first. We mean machine learning. And we mean machine learning that you can't actually look under the hood and change. That's where it gets scary. If we're talking about advanced algorithms, look, people call Facebook and Instagram listen and watch my actions, and they make predictive analysis based on that. I've heard that used in tests like today and called it AI. It's not AI. You can change that algorithm. You can change how that works. Programmers can go in there and change it. AI, you cannot change. You cannot look under the hood. And so I think we just need to be really accurate about what we mean by AI. AI is meant to mimic a person. And that can be really amazing, especially for healthcare. And so I think things we have to talk about is, well, what data inputs go into that machine learning? Is it everything? That's how you get ChatGPT. And what kind of person is it mimicking? A good person or a bad person? This stuff gets really scary really fast. When we're talking about healthcare, it seems kind of obvious that you're going to limit the data inputs. Does that need to be a law? Is that one of the regulations that y'all are talking about? So actually, I'm going to stop there and ask you. A couple of you said that we need to regulate it, but I'm curious what you mean by that. Dr. Newman-Toker, maybe you could start because I know you said that.
Sure. Thanks very much. I think your question is very pertinent, Congressman. In terms of regulatory oversight, I do think that there are certain gaps with respect, in particular, to diagnosis in this AI space. So I believe that, for example, if we think about direct-to-patient symptom checkers for diagnosis, where there's a legal disclaimer at the bottom that says this is not medical advice, but patients are taking it as medical advice, that it's really incumbent upon us to pay more attention to that consumer health space, as has been brought up previously.
So kind of like a digital watermark almost. Like I've talked about that before with respect to AI. Like it should be known that whatever this output is from AI, not a person.
Right. Not just that, but when people are making decisions about how and when to access the healthcare system, and it's based upon some kind of algorithmic decision making behind the scenes, there should be an accountability in that framework. And right now, there isn't any accountability to everything that exists outside the proper confines of, say, the hospital setting or a clinic. Before you get to the healthcare system, there's a lot going on that we need to regulate.
Can you give me an
better.
example of what you mean by that?
Yeah, so let's say that somebody types into their symptom checker that they're dizzy. And the symptom checker says, don't worry, it's nothing. It's little rock crystals in your ear, and
Okay.
you can stay home.
This is hypothetical, by the way, or is it not hypothetical? Is
No,
there
it's not
something-
hypothetical,
Okay.
actually. There are a lot of symptom checkers that are out there. They've been studied
Got it.
pretty
Okay.
significantly, and they've been looked at, and their accuracy is often quite low.
And these are just websites I can go
Yes,
to. They're
and-
not FDA regulated.
Correct.
Okay.
And what essentially happens is that at the bottom, there's a legal disclaimer that essentially says this
Yeah.
is just a toy.
Yeah.
If you want real medical advice, ask your medical professional. But that's not how patients are dealing with that. And I do think that some of those decision-making, you may have a stroke that's causing your dizziness. And if you need to be sent to the emergency department, but this system, this AI system that's out there, unregulated, is saying to you, don't worry, just stay home, that's a real risk to the public health.
I think there's broad agreement here that we would never want AI to operate independently. Maybe not never, right? We might be in Star Trek mode at some point, but like definitely for foreseeable future that you would always have a doctor's blessing, even because there's amazing things that can happen. We're seeing this technology coming out of China, unfortunately, and this gets to a competition problem too if we're going to overregulate things. But it's apparently diagnosing pancreatic cancer at 99% success rates. Like, whoa, that's amazing. Now, a doctor should still look at that after the fact and be like, yep, it is pancreatic cancer. But they're just amazing things that we can do with this technology. There's also amazing risks that can happen, especially when we're talking about that more generalized, generative AI, which is basically mimicking a person. And again, the question Congress has to ask itself, whether it's healthcare or any other conversation about AI, is what kind of person is it mimicking? We don't know the answers to that. And we have not talked about it enough in this Congress. So I'm glad we're doing this hearing.